not to confuse the audience, is that the word seizure disorder, epilepsy, is honestly interchangeable. Epilepsy was the term that's been used for people that would have like recurrent seizures, meaning that it wasn't just one seizure, that they would have seizures again over time, not just one, and we would call them epileptic. But the more so-called politically correct term, sounding more easier, is really a seizure disorder. In the population, 50% of individuals with intellectual developmental disabilities and cerebral palsy have epilepsy. So a very common type of complication in cerebral palsy are seizure disorders, and it says here more common in tetra or hemiplegic. That means that in particular with arms or legs are involved. So more significant brain dysfunction equates mostly towards more difficult or frequency or commonality of seizures. 21% have IQs greater than 50, and then more people who have less than IQ of 50 seem to have more of a propensity of seizure disorders. And in this study that was done from 2001, a number of people, greater than 40% of people or so, were living at that time in residential care facilities, which is down now because of the social issues of where people live. Diagnostic treatment challenges is really common in this population with seizures, and I'm going to go through what I have now on the slide, but I'm going to come back through this throughout the next 45 minutes. Refractory epileptic syndromes I'm going to talk about. I'm going to talk about the issue of multiple seizure types that individuals may have. I'm going to talk about the issues of frequent status epilepticus and what that word means, as well as clustering of seizures. I'm going to talk in some length about the complication issues of individuals who are on seizure medication or anti-epileptic drugs for maybe years and years and years, as well as a complication of polypharmacy. Polypharmacy is multiple medications, both for seizures, perhaps, as well as general medical issues, and what the implications are on that. I'm going to talk in some length about the side effect issues and what that means, how do you detect that, as well as some psychosocial issues about side effect tolerance. I'll just kind of maybe just mention just briefly, side effect tolerance basically, and I'll just mention this as a bias for care providers, is that someone would say, well, I'm going to give you a seizure medication, and the good news is I hope it reduces your seizures, but unfortunately, even though it's helping your seizures, you might have some tiredness, it might not make you feel right, but guess what, you know, that's the best we can do. Sorry about that, my friend, but unfortunately, that's too bad. I mean, I'm kind of being cynical about it, but tolerance means that basically almost like you're kind of not, you're blind to the reality that certain side effects that you yourself might think it's not a big deal, but for those that are actually feeling it, my God, please, you know, listen to me, I'm not feeling too good. I'm going to try to get into the issue of data collection and communication, which is not a small issue for seizure management and care, and then also I'm going to talk about transitioning in the general sense, and I'm going to make some flavor on that. And in the reality, as I'm going through this, as much as I'm going to try to get through this in the hour that I have or less, is each of these topics is very cumbersome, and each of them really honestly deserves a fair amount of dialogue and discussion, and I'm actually probably going to apologize up front because I think so much of these could be really spoken on and discussed in a more general term. I really think so. So let's talk about transitioning. So as I said, it's really case-based. So here is a common situation of a 21-year-old woman who at age 6 has been having seizures. She's been getting care at a pediatric neurology. She has a developmental disability or intellectual developmental disability, autism in particular, and here as an adult neurologist, I'm basically now seeing her for almost like the first time, and I learned that she's been given a diagnosis of autism. I understand that there's no particular family history of anybody in developmental family history of developmental disabilities, and as a 21-year-old girl, she's graduating out of high school into either higher education or to in the workforce or at home. That's some information I don't have at hand. I know that she's taking Tegretol or carbamazepine, and she's also taking lamotrigine. BID means twice a day. I know that she's on a Tegretol level, which is CBZ, that's Tegretol, a level of 6.8 with a lamotrigine or lamictal level of 3.3. And I do know that she's also, these medications she's on she's on generic medication. And what I understand is that her seizures seem to still occur. And the comorbid issues, meaning that what other difficulties does she have? She does have autism, and associated with autism, she has certain challenging behaviors, which basically might or may not be relevant. So that's some of the general information that's provided to me. And the one thing that I would say that's very important, is she coming by herself? Well, that's also an important issue. Is she coming in with a family member? Is she coming with a parent? Is she coming with a support care provider, a friend? Who is she coming in with, and what kind of information am I getting? So really what it is that I want to know is, I want to know why, these are the questions that I ask in my first visit or time when I'm meeting individuals transitioning from pediatric care into adult care. I never met her before. I don't really know her, and obviously she doesn't know me. And so coming up front, there might be certain biases that probably in many cases transitioning is that she's probably getting care for someone that's known her, put a lot of effort in, develop relationships and communication with them, and let's say this much trust. So she might not even know who I am or know that I even care about her or understand her life situation. But what it is that I want to know is, what is the cause? Why is she having even intellectual developmental disability and autism? And in many cases, the information that I have in someone who's 21 or such, I may not even know what did cause her autism. And the diagnosis and reality of autism might be very salient to me as a neurologist to understand what drove it. What drove the intellectual developmental disability that made her have autism? Could she even had another condition such as cerebral palsy with autism, or Down syndrome with autism, or Rett syndrome causing autism, or maybe the cause wasn't known, or even perhaps Fragile X. I want to know, why is she having seizures? Well, one thing they'll just mention is that in people with autism, I didn't mention this in my earlier slide, is that autism, absolutely, in people with autism, they do have a higher propensity of developing seizures at some point during their life. And I also want to know what kind of seizure she has, because in many cases when people see me, the information provided to me may not be so obvious. I want to know what kind of workup she had. Did she have an EEG, MRI? And also what's important for me to treat her seizures is do the seizures that she have affect her daily life or quality life? Do they miss? Is there any risk for injury? Does she have any? Does it make her sedated? Does the seizure cause her to kind of miss work or school? And then not only, but the seizures, do the medications affect her quality of life? And then I want to know what medication she's been on and what have they failed. And the reason I'm querying these questions to you in the audience is because in many cases, for me to know what to do in the future, it's hard for me to move forward exactly without knowing what some of these issues really are. I'm going to talk in the next slide about comorbidities. I'm going to come back to that. But also I'm going to know what is being done to monitor or measure the amount of seizures. Does she keep a calendar? Does she keep a record? Are there information that she can bring to me that would give me some information that would help me care for her and her seizures? And the other important part is how, in many respects, does her communication with the individual? How verbal is she? Is she able to kind of explain her difficulties? Is the written material there that document these things? And also, I want to know what's the additional communication that she might be having with other care providers. Is her pediatric neurologist, or rather a pediatric physician involved? Does she see a mental health provider? Does she have other support staff that are involved? So in other words, I do need to appreciate what her cycle or situation is surrounding her, so I understand that I'm not working with her in a vacuum, and I need to appreciate that. And in many cases, what some of the challenges are in transitioning is some of the information that I ask and would like to need to help the individual, often sometimes I don't really know, which creates certain challenges. The comorbidities or co-additional issues that happen in seizure disorders, epilepsy, and intellectual developmental disability, autism in particular, is behavioral issues, and here it mentions 50 to 60%. Affective disorders mean depression and anxiety. very, very common. Very commonly, people with developmental disabilities, autism in particular, or other forms of developmental disabilities, might have difficulties that might include pulmonary or lung problems, motor dysfunction such as low body tone or increased body tone if they have spasticity or cerebral palsy, and very commonly stomach issues may also be very relevant. And one thing that's also very common in developmental populations is low bone or osteoporosis, even in young people. And the reason that osteoporosis may be very relevant in common in this population is because of either lack of sun exposure or lack of physical activity, or also because of the nature of being on certain seizure medication for many years, which predispose to bone loss. Nutritional deficiencies like B12 or vitamin D deficiencies can be very common in this population, and all these things are very important for me to be able to care and understand how to best care for the individual. The important thing for me, and I'm moving on with the individual, is how are seizures documented? Is there a calendar? Is there a record? And what I do, very important for me to kind of document seizures, is to have a very black and white description of not only the seizures, about the quality of the seizure, but also the timing of the seizure. I want to know all the details about the length of the seizure, how long does it last, what time of the day, but also I want to understand the details of the seizure in terms of what kind it is. Does it have it? Is it a drop attack? Do they fall down to the ground? Is it a staring spell? Is it a quick jerk? Is it what is it called, a generalized tonic-clonic seizure, or what used to be called a grand mal seizure? So the quality and nature of the seizure is very important for me as a neurologist, as a seizure doctor, to be able to help understand this. And the slide that I'm showing on the screen is what I wouldn't say I use this as a mandatory fashion, is I use this online seizure calendar called seizuretracker.com. And it's free, so the seizuretracker.com, anyone can look at it. You go on seizuretracker.com, you look at it, it's free to sign up, and you register, and it's HIPAA compliant, meaning it's secure, and the individuals themselves, family members, the individual themselves, support staff, put the information in, and what it does, it stores the information online. It creates a digital diary of detailed information and creates charts and graphs that can be easily accessed and downloaded by the individual and also in the doctor's office. So when I see people coming to my office, I say, how are you? How you doing? Tell me about your seizures. And I immediately go onto seizuretracker.com, and without me going through papers and pencils and all this information with records or calendars, I go on and I can see right in front of me over time, from month to month to month, how the seizures that they've been having go on. Have they been worse? Have they been better? What kind of seizure types? And I can actually get a real flavor on the nature of their seizures. So really what it is, again, transitioning is such an important issue about me as a neurologist helping them. And the information that I am provided by the pediatric neurologist will help me, but as I get in and care for them, there are certain facts and information that I need. And so my sense as a neurologist who's up on the picking end of caring for them away from the pediatric neurologist, I hope that this information is qualified and papered or sent to me so that when I see the individual, that I have all this information over time, and it can be summarized or put into a detailed information that helps me to kind of fluidly pick up the patient in terms of their care and be able to manage them on. And if not, if I don't get this information, that's where problems often occur, of difficulties. And again, I could have spent more time on transition. I apologize because it's really an important topic. The other important topic is also related to polypharmacy, or the usage or individual being on a lot of medication, and also the concern about adverse drug reactions or side effects. So the case situation that I'm alluding to is really a common scenario of an older person, a 50-year-old man, who has a known history of intellectual and developmental disability. He's got seizures, and also has difficulties with behaviors, gait dysfunction, walking problems, tremors, and it seems that some of the behaviors that they're talking about to me are problematic or difficult. So what is it that I think about as a neurologist to try to get my mind wrapped around the issues? Well, first of all, I want to know what are some of the current difficulties. I want to know about their cognitive or mental state. Do they feel tired? Do they feel slow? Do they feel they're not able to understand things? And I have to get that information from the individual or the care staff, because I want to know if they're having side effects or difficulties. Is some of those behaviors that they're having, could they be simply side effects? So I want to understand exactly what kind of difficulties they're having. So I want to understand if side effects are related to mentation difficulties, but also I want to understand is some of the difficulties that they're having are physical difficulties as to underlying difficulties with their physical state. Are they becoming more weak? Are they becoming dizzy? Are they becoming unable to focus? Are they difficulties with their organ systems? And that leads to understanding about the systemic problems such as their kidney, their liver, their blood. And so also what I want to know is I want to understand in this individual that's coming in to see me is are they having all these issues, and I have to understand the big picture by getting information that would include lab evaluation that can help me lead to this. The other thing that I'd be talking about is the information related to the individual who has what's called conversion to monotherapy. And this individual that I'm talking about now, as they turn out without giving the depth of it, is they're actually on multiple seizure medications. And for a lot of individuals who may not appreciate it, in many cases, in the review of a lot of people with intellectual developmental disabilities, the average number of medication that a lot of people take can be up to like 9. So just think about it. You have someone who has seizures. They've got maybe blood pressure. They got behavioral issues. They've got issues with cholesterol. They've got thyroid issues. So here they are. They're on multiple seizure medications. They're on multiple behavior medications, or multiple this, that, and the other. And they're coming in. They're not feeling right, and they're acting out. My goodness, can you only appreciate what they would feel if they're basically on over-medication? Without asking anyone on the call tonight how many medications you take and how you would feel if you're on 9 medications, and just say you're feeling out of sorts, you're feeling tired, you're feeling dizzy, you're feeling stomach upset, you're feeling off balance, you're feeling anxious. How would you be able to explain that to your practitioner or family or anyone supports you if you're not feeling right, if you have maybe some difficulties on expressing yourself or explaining yourself? And sometimes what happens in some people with intellectual developmental disabilities, the way that side effects may manifest or adverse drug reaction may manifest is they might not act right. They might act out. They may not feel right, and so their behavior might be bad. So unfortunately, when behavior is not quite right, then what often happens, sadly enough, is more medication might be provided to curb or reduce or affect their behavior, rather than dealing with the reality that maybe some of the reasons they're not acting right is they're over-medicated. So the concept that we look at is what's called conversion to monotherapy, to see, at least from a seizure medication standpoint, is maybe if they're still having seizure and they're taking a whole bunch of seizure medications, maybe instead of being on 2, 3, 4, 5 seizure medications, maybe if we'd reduce the total number of seizure medications down to 1, which is called monotherapy, maybe they would be better off and they wouldn't have any worse seizures, and that's the term called conversion to monotherapy. And there's actually a lot of studies that talk about conversion to monotherapy that show in all these various studies over time that people seem to be more awake, more alert, better seizure control, more compliant. So really, it's really the issue of trying to think that through. The other concept has to do with the types of seizure medication are on. What, are they on older medications such as Dilantin, phenobarbital, or benzodiazepine, which is like Klonopin, Valium, or Ativan, which can cause side effects of sedation? Or how about some of the newer medications that might have less side effects? So the issue and concern about adverse reaction polypharmacy is basically trying to ask questions, trying to be open-minded about some of these possibilities, and really listen carefully to what's going on and try to make certain decisions. And one thing that I've learned in my old age and working as a neurologist, I've learned this, and I always put this slide up there. This is a particular individual, which I would say was like a philosopher from basically the 14 to 1500 Paracelsus. He basically made this comment that I really kind of post a lot. It says, all substances are poisons. There is none which is not a poison. the right dose differentiates a poison from a remedy. So think about it. Let's think about common things that a lot of us may take. Just think about it. If you take Advil, you take Tylenol, you take Benadryl, you take over-the-counter medications, if you take them just a small amount, but what happens if you take a lot more of them or too much, how do you think you're going to feel? So basically that's what this means. Any remedy, any treatment has a potential to be almost analogous to what I would think would be almost like poisonous or causing side effects. So I think it's very important to think about these things, and that could even be herbal medications or vitamins. If you take too much of anything, it could have some certain consequences which could be very bad. The part of the conversation that I'm really going to speak a lot about is really what's called refractory seizures. And this is going to take the last 30 minutes or so of our conversation for challenges. Because probably one of the biggest challenges that I have in treating individuals with intellectual developmental disabilities is what's called refractory seizures. So the case scenario that I'm presenting tonight would be a 37-year-old man who has a history of intellectual and developmental disabilities and seizures since a young child, and the seizures still happen. And some of the seizures that are happening include what are called generalized tonic-clonic, or GTCs. The other term back in the day was called grand mal seizures. Tonic seizures are stiffening type of seizures. An atonic seizure is another term for that. It's called a drop attack, and also spells or different episodes which could be staring. And within this conversation, I'm going to be talking about the definitions of what are called refractory seizures or pharmacoresistant seizures. How do we define the differences between these words, refractory, intractable, or controlled? What does that really mean? I'm going to talk about epileptic syndromes that predispose people with intellectual developmental disabilities that might be more challenging and why they're like that. But also I'm going to talk about, well, are pills and medication for seizures the only answer, which is called non-anti-epileptic drug approach? What else could be done to really help them? And the one word I'll just use as I get through this is the issue that's really may be related to the term refractory. The other word is called pharmacoresistant. The word pharmacoresistant or refractory more or less means that the pharmacologic or prescription medications don't seem to cure the individual. The other term, intractable, means that not only are medications not working to stop or control or cure the person, but surgery doesn't work, vagus nerve stimulation doesn't work, nothing works, and that would be called intractable. The other concept is, what do you mean by controlled? How do you define a commonality in someone that still has seizures and you say to them, we've tried everything, you're better than you used to be, and now it's a matter, we call it controlled, and it's a relative satisfaction that the individual, the family, the doctor is basically saying that you're controlled and the amount and severity of your seizures doesn't seem to be that bad. It's a relative term, and I mention it because I think the diagnosis of saying what means controlled is relatively difficult or common. So what I'm showing you now on this slide is a sequence of events. And the sequence of events goes from the top. It says here, a treatment sequence of what's called pharmacoresistant epilepsy, and how we physicians, neurologists, seizure doctors begin to think how you define on someone to know whether or not they're basically medications may not work and maybe they're going to still have them. And I'm going to start out by going to the very top and look at this one here. It says first monotherapy anti-epileptic drug trial. So I'm going to kind of walk you through this one step at a time. And what that would mean, if I see an individual for the very first time, they start having seizure early on in their life, and I give them a drug of any kind of medication to stop their seizures. Well, what will happen is if they continue to have seizures after that means that the first drug, the first mono drug, which means one single medication, if it means that the first drug, which is any kind of medication, which is a good seizure medication, if it doesn't seem to work, what that means, and I'm going to show you this pie graph right next to this, that means that 40% of people may only get benefit with seizures just from the first drug. So the first drug that anyone tries for seizures, less than 50% of people may continue to get seizures. So in a lot of people, their seizure may not be fully cured or gone away from the first drug. So once the first drug doesn't work and I go on, I say, okay, that first drug didn't work, let me try drug number 2 of any kind. And that's now a second drug by itself. And if that drug doesn't work, that means now that only I get benefit from additional only 13%. That's terrible. Drug number 1 doesn't work, only 47% of people are getting benefit. Drug number 2 doesn't work, only additional 13%. So what that really means is if the individual continues to have seizures despite a good drug number trial number 1, a good seizure medication number 2, that means that any third drug, any fourth drug, any fifth drug, any 100 drug, that means the odds that any new or different drug, even a newer drug that's out there now in the market, the odds is very, very high that they're refractory. This is a study that came out in 2001 by Drs. Kwan and Brody through the New England Journal of Medicine that really looked at these statistics. And this is not just people with intellectual developmental disability, this is just all different people. So what happens in many people who have seizures for all their life, and many of those on the call might realize this, is they can say, well, my doctor's had me on 3, 4, 5, multiple drugs, and they still have seizures. In many cases, we can show that for 10, 20, 30 years of them having seizures in all these trials, in many cases, it's thought that you're wasting your time with all these drugs, and we should be thinking about maybe doing something different. The first thing, going back to, it says strongly, here's a number 1, it says strongly consider video EEG after 1, 2, 3 drugs don't work. And the reason why it might be important to look at that is, guess what? Maybe they're not even having seizures. How about that? And the word, what's called non-epileptic, I'm going to be mentioning this in a second, or psychogenic seizures, maybe they're not even true epileptic seizures. Maybe they're migraines, maybe they're psychological, maybe they're fainting, maybe they're sleep problems, maybe they're movement or tremor, so maybe they're not even seizures. It happens. It's not common, but it definitely happens. But if they are seizures and the seizures are manifest and the EEG shows it, and if all these medications don't work, then the thought would be, what else can be done if all the pills don't work? And I'm going to be talking about that in the next number of slides. So this slide is very important to talk about because in my world as a seizure doctor in developmental disabilities, it's very important to not prolong all these different pills when after 1, 2, or 3 different drugs don't work. And reality is they're still having seizures, that we really need to be open and consider other alternatives. And as I said on this slide, why do seizures continue? Well, maybe it's because of the fact that they're really not seizures, or maybe the fact they are refractory or medically resistant. The other question is, well, maybe the person's not taking their medication. Maybe there's a non-compliance issue. So if you can appreciate if someone's not taking their seizure medication, then of course the medication may not work, and certainly the compliance is sometimes difficult in certain people. Maybe the seizure continues because maybe the relative difficulty with their intellectual developmental disabilities, maybe it's a severe disability that creates a scenario within their brain, maybe making it that they're going to have seizures a lot. And I'm going to talk about that. Maybe the medication they're on, it says wrong anti-epileptic drug, or maybe the blood level. Maybe the medications are wrong. There are certain seizure medications that basically are better for certain seizure types. And again, I could spend all day talking about this. There's a lot of nuances about the many different seizure medications out in the market, old and new, that some seem to be work better on different seizure types than other ones. This slide talks about what are called epileptic encephalopathies. What this word means, these are syndromes. These are conditions that affect the brain in a certain kind of way, causing the individual to have seizures that are often pharmacoresistant refractory. And I'm just going to run through some of these relatively quickly to talk about what they are, because this is kind of relevant in the intellectual developmental population. One of them in particular is called Dravet syndrome. And Dravet syndrome is actually a very rare situation, which is a genetic syndrome off of the X chromosome. And I have seen a number of people in my clinic who have Dravet syndrome, and in fact, I've actually diagnosed someone with Dravet syndrome in age 40 because the genetics weren't really known about many years ago. So I did a genetic analysis on this woman who kept having seizures. She was significantly highly intellectually impaired, and she had gait dysfunction that was progressive. So we did a genetic analysis, and it came up with a profile of Dravet syndrome. And the reason why Dravet syndrome was important to appreciate in this person is because knowing that she has Dravet syndrome made me get a sense of what medication might be better for her. It made me get a sense to talk about her and her family, about the prognosis of her, of how her life was going to be. Because unfortunately, in adults with Dravet syndrome, commonly what happen is they basically become progressively losing functionality in their speech, their language, and also their walking over years, when in fact they might have had better abilities when they're younger. The other syndrome is called Lennox-Gastaut. Now, Lennox-Gastaut is also a syndrome that probably some individuals on the phone may know about, and it's a syndrome that's often diagnosed early in childhood. And the typical characteristics of Lennox-Gastaut syndrome is the individual may have different seizure types, not just generalized tonic-clonic, not just a drop attack, not tonic seizures. They actually have multiple seizure types. And one of the common seizure types that people Lennox-Gastaut have is they often have what are called drop attacks or atonic seizures, where all of a sudden they become limp, fall down the ground, they might hit their head, and that's a situation where individuals might have head injuries or trauma, and this is a situation where often individuals might be wearing helmets because they might have injuries. Another common seizure type is also what's called a tonic seizure, where they might have a stiffening type of seizure or tightening up. And what happens in Lennox-Gastaut, they also might be pharmacoresistant, and also in all these syndromes, the Dravet, the Lennox-Gastaut, etc., also will have intellectual developmental disabilities. And in some of these seizure syndromes, they also might have brainwave EEG or certain characteristics on scanning of the brain. West syndrome is another rare syndrome where they might have what are called infantile spasms early on, and infantile spasms of a type of seizure phenomena where they basically stiffen up or almost like jerk over, and steroids or what's called ACTH might be used for them as in very infancy. EEG patterns are seen, and they all have intellectual developmental disabilities, and also as they go through their life, the seizure types that they have might also change as they get older. It's not a common syndrome, as the other ones are not very common either. And then finally, just another name of another syndrome is basically what is called the Landau-Kleffner syndrome, which is also a rare syndrome, which is also called infantile acquired aphasia. And what that is, that's a syndrome specifically where children or individuals, pediatrics, basically lose the ability to speak or talk, associated with intellectual developmental disabilities and multiple seizure types. So these are just a list of a few seizure syndromes where people might have refractory seizures. Seizures are bad. So when there's recurrent seizures, injuries happen, falls happen, trauma happens, and also toxicity. Toxicity would be a lot of medication, quality of life can be impacted, a lot of these things, and also, unfortunately, SUDEP, or sudden unexplained death in epilepsy, is a sad but tragic phenomena where people all of a sudden, they die. And it's thought that maybe they might have an adrenaline rush, or maybe their heart just stops, and all of a sudden they're found. And this happens rarely, especially in individuals that continue recurrent seizures throughout their life. There's a certain percentage. Sadly enough, in recurrent seizures, when they're still happening, the issues of what's called status epilepticus and clustering of seizures happens. Status epilepticus is when the individual will have a seizure that they might be having, but it continues on and on for over 30 minutes and doesn't stop. Or they'll have a seizure goes on, they don't quite wake up out of it, and another seizure happens, they don't quite wake up out of it, and another seizure happens. Or a cluster seizure is they'll have a seizure, they're doing okay, they wake up out of it, and then with another period of time, they start having another seizure, they wake up out of it. So it's called clustering, or a clustering of seizures. So these things are common in this population. Therapeutic options is anti-epileptic drugs, and this is the circling of different options that can be used in this population. There's multiple options, and anti-epileptic drugs in the middle, AADs, is not the only one, and I'm going to go through some of these in the remaining, quickly, 15 minutes, and I apologize. Seizure medications, and this is giving you a graph of seizure medications over history. Back in the 1800s, bromides were used, borax, and you probably heard that in detergents. Phenobarbital came out in the early 1900s, and Dilantin you may not be able to see it fully in your slide or presentation, 1930s, 1950s, and really for quite a number of years, there really were not a lot of seizure medications out until there was a boom probably around the early 1990s, when it seemed like every year or so there was a huge growth in the number of seizure medications that kept coming out in the market all the way up until just recently. And it's really I hate to use the word flood. There's a flood of many seizure medications. So now we as physicians have all these options of trying to decide all these different new drugs. What's the benefit? What's the side effect? How does this help? Is it good for this individual? Do some work together? And I could talk about this all day long, because this in itself is a whole dialogue about what some of these are and what's the benefit in certain people. So be it as it may, the premise of refractory seizures is maybe someone could be cured. And the way I mentioned this on this previous slide is what's called the surgical option. Maybe there's something specific within their brain, a seizure, a scar, an injury, that maybe the seizure is coming from a specific what's called focus or a specific location or an epileptogenic area based on EEG and monitoring that can show if you take it out, maybe it could cure them and maybe get rid of that injury. And really that could be potentially curative in certain individuals. The other aspect, which is called palliative. Palliative means that maybe a seizure surgery could be done to dramatically reduce the total number of seizures that the individual is having, and some of the potential types of seizure surgeries which are palliative are related to certain issues related to the type of surgery that the surgeons do. I'm not a surgeon, I'm a neurologist, but I do refer to surgical centers, and some of the data that's been out there over time shows about the possibility of these different surgeries that can have the propensity to cure or remediate some of the seizure types. And this is a busy slide, but be it as it may, based on the type of seizure, the base location, it's possible that in some individuals, if they have under the right guidance and right information, they might do dramatically well by having surgery. The issue about seizure management in the developmental population, in the adults in particular, which is this is what I treat and care for, is which center would you send the person to? Would the center be open-minded from a surgical standpoint that they feel that they're deemed a surgical candidate, or they feel that they're important enough in their quality that maybe they would even want them? What's the risk of surgery? Is there danger to this? So these things all have to be weighed out. Another aspect of seizure management is diet. And what this is called, and I imagine some people on the call might be aware of this, is what's called a ketogenic diet. And the ketogenic diet basically is a diet mainly based on low carbohydrate, low protein, high fat, and basically these diets try to get the person into almost like a starvation state and what's called ketosis. And there's different kind of diets out there, and I imagine a lot of people might have heard the Atkins diet. There's another one called the LA diet. These different diets that people might use for weight reduction have been used in certain profiles to try to get people to try to improve their situation. The difficulty in ketogenic diet, and there's variations of it, is you have to be extremely compliant, because if some person won't adhere to the diet and the restrictions in which this diet is, all of a sudden their seizures can go from bad to worse and even go into status epilepticus. So for me as an adult neurologist, the ketogenic diet is something that I don't often see, and it's often something in ketogenic diets is often done in many cases in the pediatric world with control by parents in situations where they can maintain them. The long-term adverse effects in certain people with ketogenic diet is somewhat unknown. It's unclear how it affects fat buildup or the bone densities or sugar control. So it's unclear the nature of it, but in some cases it might be open-minded towards thinking about ketogenic diet. There are certain syndromes, and I mentioned this on a previous slide about syndromes, is there are certain syndromes that have had more study that seem to be looking at certain possibility of these syndromes and conditions that might be more relevant to getting benefit from ketogenic diet. Neuromodulation is another option for people that have seizures that continue. Vagus nerve stimulation, deep brain stimulation, with something called responsive neurostimulation, and transcranial magnetic stimulation. And this slide, again, I wish I could spend hours talking about it. This slide talks about two different types of electrical stimulation to the brain. One that's been around since the mid-1990s is the vagus nerve stimulator. And the one that's more recently is called the responsive neurostimulation type of device, which is also out there more recently in the last number of years in certain centers, and I'm going to discuss that briefly. The vagus nerve stimulator, it shows a picture here where there's a device which is called the vagus nerve stimulator. It's almost like a small metal device. I hate to use hockey puck because that's kind of dramatic. I'll use the word pacemaker. That's probably more like it. It's a metal device with a battery inside, and it's surgically implanted just under the skin below the collarbone. A wire comes out of the device. They call it the pulse generator or stimulator, and the wire comes up, and it's under the skin, and it's surgically tied around what is the vagus nerve on the left. The vagus nerve then has direct in connection to the brain. And what this does, what the vagus nerve stimulator does, is it automatically, with the way it's being turned on, automatically turns electrical stimulation intermittently into the nerve to the brain over time to reduce the frequency and severity of seizures over time. How this works, how it affects people is somewhat unclear, and I do this on people, quite a few people in my population of even developmental disabilities, because the nature of pills haven't really worked. It's been FDA approved for what's called partial onset seizures since the mid-1990s, and it's something that it continues to be developed. And the one thing that's different with the vagus nerve stimulator is people can use a magnet. And the magnet is like a little, almost like a refrigerator magnet that the care provider, family, or others can use, even the individual, to kind of move over the skin where the stimulator is under, to all of a sudden turn the device on immediately to stop the seizure if it's happening at that moment. Almost like if you're giving someone Valium or Ativan or some kind of medication, is that the turning of the magnet on might almost send an electrical shock to the nerve, to the brain, to hopefully maybe stop the seizure, so maybe they can get out of the seizure quicker, or it could stop the seizure so it doesn't last as long. The newer device, the responsive neurostimulation, is a surgically implanted device up in the skull, in the brain, on top of the brain, with a wire placed exactly over the region of the brain where the seizure is coming from. And this is thought to basically reduce seizures, and it can almost like communicate to the brain and try to stop the seizure almost like when it's happening. And the individual might have their own ability to almost help regulate the device itself. I don't have a lot of experience with it. It's a relatively new device that's been looked at, and more to come on that in future probably discussions. The other thing I want to talk about, and I'm actually going to finish up with this, and I thought I really should mention this, is medicinal marijuana. As a neurologist who does treat developmental disability and refractory seizures, I am legally able to prescribe in New Jersey, where I work, cannabinoids or medicinal marijuana, and it is an indication that I do use in the patient population that we're speaking of tonight. Nothing new about cannabis. It's been known about since 8000 BC in China. They use it because the fiber for rope. It's been grown. It's been used for different purposes, and over time, it's been used for different medical purposes over history, for menstruation, for rheumatism, malaria, constipation, absent-mindedness, and even in China in the 1st century, many ailments were thought that it was help. Medicinal use of marijuana, cannabinoids have been known throughout the world. Nothing new about it. However, there's old case reports that maybe medicinal marijuana, or using it for medical purposes, had medical purposes that might have prudence or improvement in seizure control. And this slide is a chemical slide, just talks about what actually is within marijuana, the ingredients of it, which could actually help people perhaps with seizures. Well, certainly, as everyone can appreciate, marijuana is also used for people to get high. But what it is the components of what it is the part that's actually known to be so-called psychoactive, or THC, is what's called a CB1 agonist. And there's a chemical nature of it, this weird squiggly line here. That's the chemical nature of what's called the cannabinoid of THC. But the part that's actually been seen to be helpful for perhaps seizures is what's called CBD, or cannabidiol. That's the part that I'm going to be speaking about. CBD and seizure thought has been something that's been looking at over many years, and there's been a lot of case reports, and many case reports look at even in animals or rats who might have seizures, and study after study shows that seizures might be improved in different animals, and they wanted to see how safe it was in animals and regulate them to see if it would help them. So there's a number of people, rather an animal studies over time, that were shown that seizures might be improved over time. Back in 2013, more and more studies used to be looking at a pediatric population where they were given the CBD population or strain of medicinal marijuana that had very low THC, high amount of cannabidiol, and it was shown that in certain populations there was an 84% reduction in seizure frequency. Some were seizure-free, some had a certain percentage or reduction in this. And then more data seem to show that maybe there's certain populations of individuals with seizure syndromes that might also get benefit. So more and more seem to be looking at certain seizure syndromes like Dravet syndromes or Lennox-Gastaut over time. One of my colleagues at NYU, Orrin Novinsky, began also looking at studies on this population of people, and he had a study that used 98% of the usage of this particular cannabidiol, where they're enrolling 25 individuals, children in particular, who had various epileptic syndromes. And they started enrolling different people to see if there were really more to it, and they put out a paper that seemed to show more and more about the potential usage of it. And finally, because of the fact that there is certainly a lot of known about it, but also it's inflammatory when people think about medicinal marijuana or cannabinoids using for people, is because of the fact that for decades and eons people are worried about is it a drug and how it could be influential in people. And so really it's a hot ticket item in terms of what it was used for. And so even the American Epilepsy Society just a few years ago put out a statement that really talked about their own view and how they really felt about the ability for medicinal marijuana. And they really did say, to be more liberal, that they really were open-minded in the American Epilepsy Society about the fact that even though there's not tons and tons of detailed information and research about it, they really felt that they hoped for more research, but they really were open-minded in certain populations of individuals to really go at and try to show that this would be something that certain people, practitioners, might want to try in certain population of people, like I am doing. So I wanted to kind of just thank you. This is kind of a rush through a lot of nuances within challenges of the nature of the population of people with intellectual developmental disabilities, challenges of transitioning, challenges with polypharmacy, challenges of refractory nature or pharmacoresistant. I also was thinking that I was going to even throw in there, which I could not have time on, the issue of what would be deemed acute seizures. The ability when someone's having a seizure to actually, what do you do with them and how do you treat them when the event occurs? How do you do the first aid? How do you manage them? But I basically realized if I tried to do that, I would no way be able to get through even what my presentation was. So we're basically getting close to the end of our time, and so Mike, I'm going to bring you back on, and I don't know if you want to open up. We just have a few more minutes, if there's questions. I guess we didn't really ask people to kind of throw in their text messaging or all that. I guess we could have done that. But so Mike, how would you like to proceed at this point?
So I was thinking about that during the presentation, which by the way was very good. Thank you very much.
Thank you.
And if you didn't bring up cannabidiol, I was going to ask you about it.
There you go. I beat you to it.
You know, what do we have? We have 25 people on. We might get about 8 questions. I think if people want to raise their hand, I can click on them to unmute themselves, and they can just talk to you, ask you a question that way.
Yeah, I mean, that's fine. Yeah, and honestly, people can always, leave when they can. You don't have to stay on at 9:30. I can definitely stay on probably for another 15 minutes. So I'm more than happy. And also, there's my email address, sethkeller@aol.com. I certainly wouldn't mind to kind of field questions or even have an email. And also, Mike, I don't know if you mentioned this, maybe you did, is this lecture, did we record this? Was this recorded?
We did. This is the first time I forgot to record it from the beginning, but I didn't miss any of the content. I only missed the introduction that I gave.
Mike, you're fired. You're fired. So basically,
you were still giving the overview of what you were going to talk about. So
and where will this be available? Archive version and the PowerPoint or PDF? What's that about?
Right. So all of the recorded virtual grand rounds are uploaded onto the AADMD YouTube channel. So you can go to aadmd.org and it's on the front page. Click to the link, or if you go to YouTube, you can search AADMD, and there's the virtual grand library comes up, and you can see, I think we have 15 recordings up right now, and this will be up there later on this week.
And Mike, what I'm thinking is that also, since this, again, I know that you have a lot of other speakers over time, I could also maybe come back and basically expand the presentation and maybe just focus on one area, because it really is a challenge. And I think one thing that I see, and I can keep talking a little bit if anyone wants to throw in a question, is that this is probably one of the challenges I see commonly, where people are very frustrated, and a lot of doctors, especially caring for people with developmental disabilities in neurology, don't have a comfort level on how to be aggressive, and often people are a little slow to reduce polypharmacy, or think about conversion to monotherapy, or think about new drugs, or think about alternative treatments, or surgical management. And I think there's a certain innate bias sometimes in adults that certain practitioners may not always be aggressive. And I think what's very important is the advocacy, the role of the family, the role of the individual to really know for them is what to expect in terms of from their practitioner. How much should they expect? How much should they expect from their practitioner to be, trying and helping them? So I think there's a patient part of it where people really need to have some appreciation is what's so-called normal treatment. What should they really get from their practitioner to know whether or not they're getting so-called adequate care? And that's a challenge, but people shouldn't always settle.
No,
they really shouldn't.
Maybe we could put together a series. That'd be great. I definitely think
I could certainly do that. And I know that in around the country, there are individuals also, I mentioned Orrin Novinsky and others around the country, who definitely see a good percentage of people with developmental disabilities who have it. The one thing, Mike, and I'll just mention this in the waning minutes, is that the treatment of intellectual developmental disability and seizures is there's not really well documented guidelines, written guidelines that is very open to a lot of doctors to know, well, how do I treat someone with intellectual developmental disabilities? What's kind of the right kind of medication? What do I do if there's a compliance issue? What do I do if I can't get an EEG? What do I do if I think about alternative treatment? So there really isn't great guidelines. And then what I do nationally as a neurologist, Mike, is we're working to try to create some of these to bring more awareness and attention for these issues. So that's very important to do. So we're trying to create guidelines. So any questions? Anybody out there raise a hand?
I just unmuted our first live question. So
go ahead.
Go for it.
Hello. Who is this? If you can state your name.
Hello? Laura? Should be a Laura Kelly. I unmuted.
Does she have a microphone?
I believe so. It says she.
You could also text it, right? You can also write it in the message block, right, Mike? Right. There's a block below. You could write a little message.
Right.
Because I didn't.
As we wait for that, we have one more question. In case our participant's microphone doesn't work, but Lou above asked, as a dentist, she's concerned about treating people with a history of seizure disorder, whether their condition is stable. Are there good questions for them to ask to assess stability besides the frequency of their episodes, like what sets them off, what medications they take?
Hello, Lubov. Great question. Lubov is one of our leaders within American Academy of Developmental Medicine and Dentistry, who basically is asking a great question. And it's really what it is that when there's a procedure that's going to be done on someone who might be having a seizure, surgery, oral health procedures, and you're trying to keep the person, comfortable and stable and not moving a lot, what's the risk if they can have a seizure condition? Well, let me put it this way. One of the benefits of doing a procedure is often anesthesia. If there's like general anesthesia or even sedation, that's actually one is a great medication. So I rarely, and I can't think of in my 25 years of any complication that I've ever seen in someone with refractory seizure or seizures that ends up having some kind of complication from dental care, a surgery, or a complication because they're a known epileptic. I've not seen that. And in fact, Lubov, what I see is the practitioners who may not be enough knowing about it, they ask me to so-called clear the person. They would almost like want me to write like a little note saying so-and-so is stable to have a procedure because they've got a seizure disorder, because in a lot of cases people worry that they could have a seizure during the event. The only thing that I think about procedures is someone that is not able to take their medication for a while. So in certain people that have surgery and they're not able to take their pill for 3 hours, 6 hours, is they could have a lowering amount of their medication or blood. That's something I do care about. So I'm often very much advising people not to take their medication before their procedure, and as soon as their procedure is over, if they need their next pills, take it again. And also some of the seizure medication is available in intravenous form. So sometimes people that are not able to take medication by mouth, they can take an injection, and even some medication or by liquid. So sometimes if they have a J tube or G tube, they can get the medication that way. So that's not quite your question, Lubov, but there are other ways of doing it in. I don't know that I answered it fully, but that's my sense about stability in this population with procedures.
Okay, actually we have a few more questions now.
Oh, okay, I'll try to answer them quicker then. Go ahead.
No worries. Like you said, if anyone needs to duck out, they certainly can. And if they want to check back later and skip to the end of the recording when they look at it later, they're also free to do that too. But we have a mother who has a daughter with autism, LGS, autism, Down syndrome, and she's a seizure disorder treated with midazolam for rescue medication, giving intranasally. But with such a system, she said it's hard to determine when enough has been given. And I don't know if you have any advice on that. I've never heard of such a rescue.
Oh, well, I'll tell you all about it. Yeah, basically, I even kind of threw at the end, I was going to talk about acute seizures, is that what happens is that when someone's having a seizure, you want the seizure to stop. You don't want it to last a long time. You want the person to come out of it. So there are specific remedies, medications that can try to stop the seizure. And the best type of seizure medication that can be used to stop a seizure is what's called a benzodiazepine. That's the chemical nature of it. And the kind of benzodiazepines that are available on the market, Valium, Klonopin, Ativan, Xanax. I'm sure a lot of people on the phone may have heard about them. Well, there's one that's an intravenous one that's known as midazolam, which is what you're mentioning. And the other name for midazolam is Versed. Versed is a common anesthetic. It's actually used commonly for people that are having a procedure to kind of like, knock them out and keep them sedated for a while. It's intravenous. And it's been known that midazolam could also be used in an aerosol or spray and dripped into it could be made into a nasal preparation to drop in the nose, so the nose would absorb it and it would get into the blood vessel nose instead of trying to swallow a pill or use an alternative such as the other one, which is called Diastat, which is a rectal suppository of Valium. So there's been what are called compounding pharmacies, And the compounding pharmacy is not like your typical CVS or Rite Aid or Walgreens, is they take the Versed or midazolam, they mix it up from the intravenous liquid, they put it into a dropper form in a certain concentration, and the neurologist who prescribes it would tell the individual how many drops they can use. And as the individual, as you're speaking about, is what's the right amount, it's hard to know. It's all individualized based on body weight, I believe. And so right now, it's often starts with a certain amount of drops, and the doctor would then, I guess, ask, did the number of drops seem to stop the drops into the nose, stop the seizure quickly? And if not, then they might increase the number of droppage. And also, what happens if you give too much? Well, the difficulties of giving too much of any of these medications is too much sedation, and that's always the challenge. It's not always easy to give midazolam because you have to find the right pharmacy, compounding pharmacy, to do it, and you have to have the right practitioner. I was going to say open-minded, that's basically liberal enough to kind of really feel comfortable going to this kind of preparation.
It's interesting.
Yeah.
Obviously, especially something administration like that, benzos are not as much of.
You're in surgical rotation, Mike. So you're going to learn that. You're going to learn about Versed. You probably heard of it, right? Versed. It's Versed.
Let's see. This participant asked, at what age would you no longer consider surgery or polypharmacy? Basically, the only reason I probably wouldn't deem surgery an option, and this would be, I'm not going to be cold and cruel about my comment, is in someone that basically is a terminal illness. If someone basically is like has a certain kind of condition where it looks like your life expectancy is short, then it wouldn't, relatively short, then I don't think any surgeon would really opt to want to do surgery. When surgery should be done otherwise, I think it can do it throughout your lifetime. I don't know if I would consider brain surgery or seizure surgery in someone in their 70s or 80s. I suppose you could, but I think you can think about seizure surgery throughout the lifespan. The only issue with seizure surgery is probably finding the right person who has the right location in their brain that could have surgery. An example of someone that might be a benefit from seizure surgery even later in life is someone with tuberous sclerosis. Tuberous sclerosis is what's called a neurocutaneous syndrome, where there's growth within the brain called tubers that creates the seizure. So if they grow, you can actually take that out by surgery, and you might have a great reduction of their seizures. And I'm certainly thinking that that's something that could be done throughout their lifespan. Throughout that. What was the other part of the question, Mike? I kind of missed that. Sorry.
Seizure surgery.
Sorry, I was searching through.
Okay.
Where were we?
I was yammering on. I think there was a second part of the question.
At what age would you no longer consider surgery or polypharmacy?
Well, polypharmacy, I mean, again, polypharmacy means multiple drugs. Sadly enough, I never want polypharmacy, and polypharmacy, again, could be not just seizure medication. I think, unfortunately, polypharmacy happens throughout the lifespan. In geriatrics, I think many older people are on many different drugs, and you can even ask your mom and dad, your grandparents, how many drugs they take. They're on polypharmacy. So I think polypharmacy is the more medical issues you have, people are taking more medication. So I think that's the nature of multiple medical problems, getting older, and polypharmacy is certainly not inherent to a developmental population. It's inherent to anyone with chronic medical problems or getting older, and it creates problems throughout the lifespan. So it happens all the time, unfortunately.
Let's take two more questions.
Okay.
We have, one says, where might we find guidelines for practitioners to treat persons with IDD? We have approximately 3 doctors who primarily treat persons with IDD.
What I can do is I can actually send people a link. There actually are articles that have been published about that. Now, the links themselves, one of them is an article that I was involved with that we published, I believe, in 2015, but there are some nuances that are published out there that you could say are guidelines. So, Mike, what I could do, and I can't give you the link right now, I can try to dig that up and forward that on about that. There's one that came out, I believe, in 2001 out of England that's also a guideline for seizure management in developmental disabilities. So I can try to find these links and give it to you, and maybe you could put it on the website, or maybe you could email it out. I'm not quite sure.
Yeah, so I can email it to, sorry if you hear that noise in the background, I live in New York City and my pipes, they make strange noises sometimes.
Okay.
What I can do is I can email it out to everyone on this list, and I can post it along with the description with the finalized recorded version.
Okay.
All right. So the last question is from Lynn Tecklett, another one of our AADMD members and board members, in fact. And so her question is that she seems to see a lot more patients recently with LGS, and she wants to know if you think it maybe is an increase in occurrence, or do you think it's more accurate diagnosing?
Lynn, great question. I think really what it is I think there might be more of a recognition of it. And I'm just curious, Lynn, I kind of forget, if is this a question of in pediatrics, or I kind of forget, Lynn, in pediatric cases, or what age are you talking about that you're seeing? Are you able to get on the phone, or can you ask that or answer that? I'm trying to remember what age are you seeing this in? That'll help me answer your question.
I can, if she wants to.
And again, LGS is Lennox-Gastaut. And I think really what it is that I know that what I see, I treat all adults, I don't treat children, is that I care for a lot of people that have multiple seizure types, and they label or diagnose of Lennox-Gastaut. They may never have had, or maybe I just kind of make it in older people. I think partly it's just a recognition of it. So is Lynn able to get on the call?
If Dr. Tecklett has a microphone, she can unmute herself.
So I was just curious, Lynn, about the age.
But she did say, respond that their centers for adult patients, dental treatment for patients with
adult
disabilities. Yes.
Well, I think in adults, basically what it is, it's probably more of a marketing and awareness campaign, because what it is there are a few seizure medications, Banzel in particular, and Onfi, another medication. They actually specifically are seizure medication indicated particularly for Lennox-Gastaut. So I know that the companies themselves, Lundbeck Pharmaceuticals and Eisai Pharmaceuticals, the maker of them, they basically are in marketing to try to create an awareness of people who might have Lennox-Gastaut during their life, and that's kind of really where the awareness might be coming in. There's also a Lennox-Gastaut Society or Foundation that also might be doing marketing and trying to make an awareness of these various syndromes out there. And it's important to know if someone has Lennox-Gastaut, because you get to know that they're medically refractory, you get to know that there's certain seizure types, you get to know that there's certain medication might be beneficial for them. So it is important to understand, what is the reason why someone's having seizures, but I think it's an awareness campaign and knowledge about more people knowing.
Yeah. Great. Great. Well, thank you once again, Seth, for coming on and giving a great presentation. It was very educational and I think very interesting as well. And so, like we were talking about earlier, everyone, if you're still on, this recording will be uploaded to the AADMD YouTube channel later on this week. So if you're interested in showing it to anyone, please feel free to. We love offering these as free educational platforms for people to kind of get a better understanding of how to treat these individuals. So.
Thank you very much. Yeah, Mike, thank you. And again, I want to appreciate the audience for coming on. And the AADMD Virtual Grand Rounds has been a great opportunity. And Mike, I want to really personally thank you for taking the lead and helping to own this effort. You've done a marvelous job, and thank you again.
It's been a lot of fun. I've enjoyed it. And with that, I'd like to say good night to everyone. And thank you once again, Seth. It's good talking to you.
Good night, everyone. Thank you all. Bye-bye.